It's now 1:50 p.m. and we will reconvene the meeting to begin the oral public comment session. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's important that each speaker limits his or her remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. Our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at our two-day meeting. Thank you again to our speakers, and we look forward to your comments. Our first speaker is Diana Olson. Ms. Olson, are you on?
Yes, ma'am.
Okay, you may begin.
Thank you. This is Diana Olson. Thank you for the opportunity to comment on behalf of the National Foundation for Infectious Diseases, or NFID. NFID commends the independent experts of ACIP for the countless hours spent reviewing and analyzing vaccine safety and efficacy data and the role they play in helping to protect the health and the well-being of individuals and communities across the U.S. Vaccination saves lives and has a positive impact on the U.S. economy. ACIP will soon vote on vaccines for COVID-19. Since the pandemic began, according to conservative estimates, COVID-19 vaccination has prevented more than 18 million hospitalizations and 3 million deaths in the U.S., saving the U.S. economy more than $1 trillion. But vaccines are not effective unless they are used. Only about 12% of U.S. children and 22% of U.S. adults have received an updated 2023-2024 COVID-19 vaccine. Among adults aged 65 years and older who are at increased risk for severe complications, less than half are up to date on COVID-19 vaccination. Immunization rates for other recommended vaccines also remain below public health goals. Only about half of U.S. children and adults have received an influenza vaccine during the current season. Despite the availability of new interventions to help protect against RSV, only about 22% of eligible adults aged 60 years and older and about 16% of eligible pregnant women have received an RSV vaccine. Clearly, there is more work to be done to build vaccine confidence, address health disparities, and increase overall immunization rates. NFID and partner organizations support the following. 1, implementation of a Vaccines for Adults program to build upon the Vaccines for Children and Bridge Access programs and further expand access to these life-saving tools. 2, continued support for U.S. vaccine safety systems, which are among the most comprehensive in the world. And 3, strong public health infrastructure to help ensure that ACIP, CDC, and state and local public health agencies have the resources to do their important work. NFID commends the tireless efforts of ACIP, and we stand ready to work with CDC, which has been instrumental in saving lives and reducing the impact of disease.
Thank you. Our next public comment speaker is Mr. Robert Biancato. Mr. Biancato?
Yes, I'm here. Thank you. My name is Bob Blancato, and I appreciate the opportunity to speak today as I have in previous meetings. I will, as before, focus on one point. Older adults should have full and equitable access to the most up-to-date vaccines. Today, I present not only as the Executive Director of the National Association of Nutrition and Aging Service Programs, but also on behalf of 18 other National Aging and Patient Advocacy Associations who call on you to reverse your June 20 recommendation requiring shared decision-making for the use of the new RSV vaccines for adults 60 and over. The adverse consequence of imposing shared decision-making can be seen in what CDC reported on February 16th, that only 21.9% of adults 60 and over reported receiving the RSV vaccine. The agency also reported that as many as 160,000 older adults are hospitalized for RSV-related illness, with as many as 10,000 fatalities attributed to the virus each year. After decades of research into this virus, we now have 2 vaccines which received FDA approval for safety and efficacy among older adults. Despite this significant milestone in our ability to protect older adults from RSV and the CDC's RSV working group's analysis on the benefits of required vaccine for those who are most vulnerable, ACIP chose to amend the language to require shared decision-making. As we communicated in a joint letter to Dr. Romero and Dr. Wharton last August, quote, studies have shown that physicians find shared decision-making recommendations difficult to understand and implement. This is also true for pharmacies who play a critical role in healthcare access and who become the nation's leading provider of the COVID-19 vaccine. We also oppose shared decision-making making due its uniquely negative impact on vulnerable adults who are part of an already underserved communities, including rural areas or medical service deserts. We should be committed to reducing, not increasing, healthcare disparities. The CDC's own RSV working group noted that an age-based recommendation for the RSV vaccine for those 65 and over might, quote, increase equity by decreasing the RSV burden among persons from racial and ethnic minority groups and in persons with lower income status, unquote. Unfortunately, the guidance does not reflect this. We are encouraged by the CDC work group outlining an improved process to help ensure patients can receive the updated COVID vaccines. At the same time, flu and RSV vaccines are available. We think co-administration of these vaccines will go a long way toward ensuring older adults are protected well ahead of the height of the next respiratory season. We are also encouraged by this morning's discussion on the recommendation for an additional COVID vaccine shot and the resulting amendment in favor of should instead of may. If the goal is preventing serious health outcomes in older Americans from respiratory illness, clear, broad, and easy to communicate guidance should be the standard for adult vaccines. We commended ACIP for your consideration of aligning recommendations for COVID, flu, and RSV vaccines, which we know will support increased vaccine uptake among old adults, but it isn't enough. CDC must also reconsider the shared clinical decision-making recommendation for adult respiratory vaccines. Thank you very much.
Thank you. We appreciate your comment. Our next speaker is Ms. Martha Nolan. Ms. Nolan, are you on?
Sorry, I'm Martha Nolan, and I'm the Senior Policy Advisor for Healthy Women, an advocacy organization committed to educating women so they can make informed health decisions, advocate for themselves, and prioritize their health and wellness. The last 4 years have presented us with some of the most complex challenges in protecting the public from serious respiratory disease, but also resulted in some of the most innovative options for protection. I would like to use my time to outline a few areas where we believe clarification is needed and to support greater access to these innovative tools. This year, we were encouraged by the addition of newly FDA-approved RSV vaccines for adults and pregnant people and a preventative antibody for infants. For pregnant people, the availability of new RSV vaccines has been incredibly important in preventing RSV in infants. Unfortunately, we have been hearing growing concern around how the seasonal recommendations translate to reimbursement and coverage. Specifically, many are confused about whether there is a cost sharing on the part of the patient if they receive the vaccine after January 31, 2024. Because the CDC guidance notes that in certain U.S. jurisdictions where RSV seasonality differs, providers may consider RSV vaccination after January 31, but it is not clear if insurance will cover the cost. We recently joined 6 other advocacy organizations in raising this concern to the Center for Medicaid and CHIP Services and appreciate that they shared some information, but the confusion remains. We urge ACIP to consider ways to ensure there are no coverage barriers for patients, particularly when considering future seasonal recommendations. Lack of coverage for a vaccine is a barrier that often leads patients to forego that care option. We have also been discouraged by the low uptake of RSV and COVID vaccines in older adults during the 23-24 respiratory season, even though these viruses continue to pose a very serious threat to health. While women often serve as the healthcare decision makers in their family, they are only as effective as the expert guidance they are following. Despite there being many tools to protect ourselves against respiratory illnesses than ever before, there is also increasing confusion about who should receive what vaccine and when, resulting in decision paralysis and, in many cases, a lack of clarification by medical providers means less people in vulnerable populations being vaccinated. We commend the ACIP COVID work group for your consideration of providing recommendations for the use of COVID and flu vaccines by making it possible for the same provider to offer access to COVID, flu, and RSV vaccines early in the respiratory season. Patients will be able to receive these protections in the same visit, thus increasing vaccine uptake for the upcoming 24-25 season. Healthy Women is committed to its role of clearly and effectively communicating information about the latest strategies and tools for keeping our families and communities healthy. But we cannot be successful in this mission without clear and concise recommendations from the CDC. We urge ACIP to evaluate existing guidance and provide necessary changes to ensure clarity around who should receive them and when, and ensure coverage for all populations. Thank you.
Thank you. Our next public comment speaker is Ms. Hannah Burke.
Good afternoon, and thank you for the opportunity to speak with you today. My name is Hannah Burke, and I'm an educator in Washington, D.C. I'm here to ask the committee to support the proposed should recommendation on a booster dose of the COVID-19 vaccine in this meeting, and to develop action steps to go further after this meeting. We need updated vaccines for people of all ages and health statuses, covered by insurance and/or public funds at least every 6 months. I'm 29 years old, and I'm lucky to enjoy relatively good health. I'm glad that the booster access is prioritized for people like my 75-year-old father who has long COVID and my close friends with conditions requiring immunosuppressive treatments. But limiting access to older and immunocompromised adults puts everyone at risk. Twice annual vaccination is important to me for 2 reasons. First, I can only safely share space with my high-risk family and friends so long as I'm taking precautions, which include vaccinating after my immunity wanes significantly after 4 to 6 months. Second, multiple COVID-19 infections have been shown to compound systemic damage to the body that makes any person more vulnerable to illness and disability, even if they are otherwise healthy. So many hospitalizations and deaths that cannot be attributed exclusively to COVID are likely exacerbated by its long-term effects. Dr. Prosser's thorough economic analysis today includes the very important caveat that long COVID data are scarce and therefore unaccounted for. I hope the committee will approve the proposal to announce COVID vaccine recommendations on an earlier timeline this year. This measure can help ensure appropriate time to redouble our efforts and increase the visibility, urgency, and accessibility of these life-saving resources. I resonate with Dr. Chatham-Stevens' earlier statistic that only 20.4% of adults report their physicians recommending updated vaccines. So many of my friends and relatives have asked their doctors about booster availability and have been told they don't need the vaccine. Several uninsured friends of mine also received their boosters months later than they could have because they hadn't heard about the Bridge program until we spoke. Many people are willing to take precautions to protect themselves and others, but haven't received encouragement from their doctors and public messaging about the vaccine's continued importance and its availability for free. In order to build communities where all people have access to our best health and to public life, I hope the committee will issue a should recommendation on boosters for older adults and support an expedited vaccine decision-making timeline in today's meeting. Beyond this meeting, I would urge you to make updated vaccines accessible twice annually for people of all ages and at no cost, and to recommend continued vaccination in the clearest, strongest terms. Thank you for your time and your work supporting evidence-based public health policy.
Thank you for your comment. Our final public comment speaker is Ms. Maria Shreve.
Hello, my name is Maria. I'm a registered nurse and I take my job very seriously. And I know you do too. Thank you for that. You all have a tremendous weight on your shoulders, and no matter what decisions you make, someone is still mad. Sounds a lot like being a parent. As my 4-year-old says to my husband, who's a chef, everyone thinks they're a food cricket. But I'm here today to share my thoughts, concerns, requests, and constructive criticism with you today, specifically regarding children's vaccines. We are so grateful to have access to children's COVID vaccines and now the new RSV vaccine, but it wasn't easy. We're a proud Pfizer trial family, and we're grateful for the people in science that got us here today. The question I have for you all is, will you please prioritize our children this fall? I have a list of ways that you can do that, which include making children's vaccines available before school starts this year. Last year, COVID started increasing in late July, right before kids went back to school. We could decrease transmission and infection if we offered COVID vaccines to all our kids prior to starting the school year. Increased supply. Specifically, children's uptake would be higher if supply was available. Parents are much more likely to vaccinate if they don't have to hunt down a vaccine that requires 2 different appointments based on their kids' ages, as well as driving hours each way. Providing support for more accessible locations for kids of all ages. We were still crowdsourcing for appointments this fall. We need COVID clinics, just like flu clinics, just like at the beginning of the pandemic. If it needs to be government funded vaccine clinics where parents can take kids of all ages for vaccines together instead of taking one to a pharmacy, one to the pediatrician, and one to Minute Clinic, then that's what we need to do. We need a better plan for the development and implementation of more RSV and COVID treatments quickly. Unvaccinated children's hospitalization rates last year with COVID were as high as the elderly. We could, by increasing supply we could increase vaccination rates, and this decreases hospitalization and transmission. We'd also like to support options that allow access to vaccines every 6 months instead of yearly. Thank you so much for your time and your attention, and we appreciate all you do.
Thank you very much. We appreciate the comment. Thank you to all of our public comment speakers, as well as the others who requested public comment speaking time. We appreciate your interest, and thank you for the comments today. We will now move toward our votes. And can we get the first vote slide up for the COVID vaccine vote? Dr. Wallace, could you read the proposed vote language, please?
Yes. ACIP recommends that persons greater than or equal to 65 years of age should receive an additional dose of the 2023-2024 formula COVID-19 vaccine.
So before we begin to vote, are there any additional comments? Dr. Kaslow?
Thank you. If I might, I'd like to make just a few pre-vote comments. First of all, only 40% of people over 65 years of age have received the indicated dose in the current package insert for the 2023-2024 formula. The biggest public health impact would likely come from increasing the number of 65-year-olds and older getting that indicated dose. Second, there are suggestive data of longer duration, particularly against the outcomes that are most important, severe disease and death, in those who have had multiple exposures to the spike protein, be it by infection or vaccines. And in the current context, I think what we're seeing in 65 years and older is they have already had multiple exposures to that spike protein. Third, there's a paucity of evidence with both mRNA vaccines and the protein-based vaccines, given at this time in the ongoing pandemic. The context of receiving an additional dose now is quite different than what it was earlier in the pandemic. As presented, the pre-existing immunity is quite robust now and quite different than what it was early in the pandemic. Fourth, if an antigen update is recommended this year, that's an if, and if it's available in September, then giving an additional dose of the 2023-2024 formula, the current formulation, any later than June this year may not be optimal. So based on the current context and the available data, this seems truly a May recommendation supported by what is basically level 3 evidence. Thank you.
Are there any additional comments before we proceed to vote? If not, I'll ask our committee members and ex officios to turn their cameras on.
Dr. Wharton, may I make a brief comment? It's Emily from Bio.
Ms. Acker, we're not, we're moving towards votes. We're not doing additional discussion at this time. So I will go through the voting ACIP members first and then call on the ex officios. I will start with Dr. Sineas.
Sybil Sineas, I have no conflicts, yes.
Dr. Daly.
Sorry, my video is not ready. Should I go ahead and vote?
Go ahead.
All right, Dr. Daly, no conflicts, yes.
Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Long?
Long, no conflict, no.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Chen?
Wilbur Chen, no conflicts, yes.
Commander Grimes?
Commander Grimes, no conflicts, yes.
Dr. Clark?
They do get a vote.
Matthew Clark, no conflicts, yes.
Commander Marshall?
Valerie Marshall, no conflicts, yes.
Dr. Beigel?
John Beigel, no conflicts, yes.
Ms. Hance?
Mary Beth Hands, no conflicts, yes.
Dr. Kaslow?
Kaslow, no conflicts, abstain.
The motion passes 11 yes, 1 no, 1 abstain. We will now move on to our next vote on chikungunya vaccines. Can we get that vote language up? Dr. Hills, can you read this vote language for us, please?
Thank you, Dr. Wharton. Language is up. So chikungunya vaccine is recommended for persons aged 18 years and older travelling to a country or territory where there is a chikungunya outbreak. In addition, chikungunya vaccine may be considered for the following persons travelling to a country or territory without an outbreak, but with evidence of chikungunya virus transmission among humans within the last 5 years. Persons aged older than 65 years, particularly those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, or persons staying for a cumulative period of 6 months or more.
Okay, are there any additional comments before we proceed to a vote on this motion? Not. I'll start with Dr. Cotton.
Camille Cotton, no conflicts, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Dr. Long?
I'm sorry, I'm still unable to have my computer log on. Sarah Long, no conflict, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Chen?
Wilbur Chen, no conflicts, yes.
Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Dr. Daly?
Matthew Daly, no conflicts, yes.
I will start with the ex officios with Commander Marshall.
Valerie Marshall, no conflicts, yes.
Dr. Beigel?
John Beigel, no conflicts, yes.
Ms. Hance?
Mary Beth Hands, no conflicts, yes.
Dr. Kaslow?
Kaslow, no conflicts, abstain.
Commander Grimes?
Commander Grimes, no conflicts, yes.
Dr. Clark?
Matthew Clark, no conflicts, yes.
And so this passes 12 yes, and with 1 abstention. We will move on to our second chikungunya vote, if we can get that language up.
So the language is chikungunya vaccination is recommended for laboratory workers with potential for exposure to chikungunya virus.
Any additional comments before we proceed to a vote on this motion? Okay, we will proceed to vote, and I'll start this time with Dr. Long.
Here you are, Sarah.
Sarah Long, no conflict, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Dr. Chen?
Wilbur Chen, no conflicts, yes.
Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Dr. Daly?
Matt Daly, no conflicts, yes.
Dr. Cotton?
Camille Cotton, no conflicts, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Dr. Beigel?
John Beigel, no conflicts, yes.
Ms. Hance?
Mary Beth Hance, no conflicts, yes.
Dr. Kaslow?
Kaslow, no conflicts, yes.
Commander Grimes?
Commander Grimes, no conflicts, yes.
Dr. Clark?
Matthew Clark, no conflicts, yes.
And Commander Marshall?
Valerie Marshall, no conflicts, yes.
And this passes unanimously, 13 yes. And our final vote is on the VFC resolution. Can we get that vote language up, please? Dr. Santoli, would you like to read this, please?
I would, but I'd actually like to pull up another slide if it's possible, because I'd like to identify an error, a correction that we'd like to make, because we had some eagle-eyed colleagues helping us. And if you look at the second red table note, this should actually read was given after the 10th birthday, because it's after the age of 9. So we will be making that change and wanted to make sure you all were aware, and then I think we're ready for the vote.
Okay, thank you. Thank you for highlighting that correction. So we will proceed to vote on the VFC resolution, and I will start with Dr. Chen this time. Yes, go ahead.
Yes, Wilbur Chen. I have an active collaboration with Mass Biologics, the maker of a TD vaccine, as we had mentioned. I will recuse myself from this vote.
Thank you, Dr. Chen. Dr. Sineas?
Sybil Sineas, no conflicts, yes.
Dr. Daly?
Daly, no conflicts, yes.
Dr. Cotton?
Camille Cotton, no conflicts, yes.
Dr. Lair?
Jamie Lair, no conflicts, yes.
Dr. Long?
Sarah Long, no conflict, yes.
Dr. Brooks?
Oliver Brooks, no conflicts, yes.
And I'll start with Dr. Clark.
Matthew Clark, no conflicts, yes.
Commander Marshall?
Valerie Marshall, no conflicts, yes.
Dr. Beigel?
John Beigel, no conflicts, yes.
Ms. Hance?
Mary Beth Hance, no conflicts, yes.
Dr. Kaslow?
Kaslow, no conflicts, yes.
And Commander Grimes?
Commander Grimes, no conflicts, yes.
Great, thank you very much. And that passed with 12 votes yes and 1 abstention. Sorry, 1 recusal. We did just have a number of votes. I would like to invite any of the members who would choose to make a comment about any of the votes we just made to do so if they would like. Dr. Chen.
Yeah, I guess I would like to comment on the vote for the chikungunya vaccine. First licensed vaccine in the U.S., but I think that the burden of disease is global. I'd like to hope that the discussions that we had today will not negatively affect the consequences of implementation of the vaccine globally around the world. I'd like to, of course, continue to see additional vaccines for other mosquito-borne agents here in the U.S. and around the world as well. Thank you.
Thank you. Dr. Daly.
I want to reflect on the COVID vaccination vote and just make a couple quick points. One is that I personally would have felt comfortable with a should or a may recommendation, and we voted for a should recommendation. But Dr. Castle, the points that you raised don't go away after we walk out of this room. And so I feel like I want to make sure that we can take those back to the work group and discuss those, because as I conveyed, the work group had a difference of opinion about where we landed. And whether that is we have you come to the work group or we just take those points and discuss them, because we're going to have this decision for years to come, including in June. So I just want to highlight that it's a reason for us to pause. And as we've talked about, it's a reason for us to be humble. Thanks.
Thank you. Any additional members or ex officios like to make a comment? Seeing no more members indicating they wish to make a comment, we'll take a brief break and we'll reconvene at 2:30. Thank you.